basically of what you want to think about as you approach integrating behavioral health with primary care, and also some of the reasons why we're very invested in doing so. It is a good idea when you're thinking of partnering with a mental health provider to really understand what their investment is in the process, because it does take a lot of commitment to work all of these issues out, which I will outline. And for the Mental Health Center of Denver, we are very interested in doing more and more population-based care, meaning we do a great job of tertiary treatment, but we know much more about prevention science, we know much more about health promotion, we know much more about early intervention, and we're very aware that up to 70% of primary care visits are related to some kind of psychosocial issue. So the penetration in the community and the increased access by partnering with primary care is what we're after, as well as trying to intervene early and doing what we can to change the developmental trajectories of families who are presenting with issues and concerns about their children. And we're also very much about the whole person, a much more of a whole person perspective. So that's kind of why we're invested in doing this work. Before I go into kind of what integrated care looks like as we define it, there are a lot of models about service integration approaches, and I want to make sure that we outline those so that we know exactly what we're talking about. So one service integration approach is consultation, and that is where you have a mental health provider who's available for phone calls, perhaps a video conferencing where you can ask specific questions about challenging situations or presentations that you're not as familiar with, but there is no location on site of that service. Okay, this is something that's used. A lot of telebehavioral health initiatives are looking at consultation models, and telemedicine, especially for folks who have very little access to traditional mental health care. Rural areas, for instance. So we're invested in providing that kind of service for folks who don't have any kind of access typically. The co-location has to do with developing a model wherein you have mental health provision and a mental health provider, this keeps going in and out, a mental health provider on site, but it's not integrated in the sense that you're not sharing documentation, you're keeping separate records, and there isn't, it increases access, which is always a good thing, but it doesn't necessarily increase that population-based care, because typically what happens is when you're co-located, the mental health provider sees that all of those folks that you're very concerned about and have very specific issues with significant acute mental health challenges. And again, it increases access. It's not the population-based care, so there's some very good things about it, but that's the co-location model. It's basically bringing the mental health provider, providing them a space in your clinic. They do their work, you do your work, and the referrals, there's a warm handoff, perhaps, and you get, and again, those acute challenging cases are typically what the mental health provider is serving, okay? The case management driven models are typically used with, let's say you have a licensed clinical case manager. A lot of times this is, where I've seen it nationally, is when you have some very high risk acute adult populations. So you're working with a homeless population, or you're working with those that a lot of folks that you see have serious and persistent mental illness, and what they need is somebody to actually walk them through and help connect them to the resources that they need to get back on their feet. That's typically when you see a case management driven model. Those case managers are trained to do brief assessments and some brief strategies, motivational interviewing, some evidence-based practices, which are very short term. But the whole idea is to have them link the primary care with whatever resources they have. It's not co-located and it's not integrated. Are those three pretty clear in terms of the differences? Okay. So the integrated, what we're talking about is having a behavioral health consultant, a behavioral health clinician become a primary member of the primary care team. That they are fully embedded in the clinical practice. We do with pediatric primary care, and as it says, they can assess and work with children and families, providing promotion, prevention, early intervention, and treatment services in partnership, always with the primary care provider, where everything is kept in one record. And it's all, so it's available to the primary care provider, it's available to the behavioral health consultant. The notes are where they're easily accessible and readable, and it's really about providing the whole person care. Anything else about that? Are the delineations pretty clear? Okay, we can move on. You guys want to say anything about that? Why are you invested in integrated care? How's that?
I'll say something.
Go ahead.
Is this on?
Yes.
Great. What is important is that you do share those notes, for example, when she's talking about the integrated model, but even better, I think, is that the providers from both the behavioral and the physical health aspect, as it were, are just sharing consultation in real time about the patients, so the notes aren't really as important as the relationship that's developed around the patient.
Thank you. All right.
The last question, why are you invested in integrated care? I'll say for us, because it's such a, and it's the obvious thing, but it's very, very true, that the tremendous benefit to the patients in the clinic and to our medical providers.
Okay, thank you. All right, so here are some national thoughts about why integrate. And again, I'm talking, we're a child and families who invested in pediatric primary care in particular as my example. But one of the best indicators of risk for emergence of mental health issues in the future is the presence of a parental or caretaker concern about a particular behavior. And usually it's quite early, many times before a child even enters into school. So it really says that the primary care, you folks have it, you've got it down. You're doing population-based care. When you look at the data, 80% of the population has at least one visit to primary care. What we know is about 70% of those are related to a psychosocial issue. So you see things earlier than we would ever see them in a traditional mental health setting. So that's one of the really wonderful benefits of being in pediatric primary care. There are some models wherein the behavioral health clinician doesn't do any treatment, but they do all health promotion, prevention, and early intervention. So they're going in on well baby checks. They're talking to parents about their adjustment. They're doing what we call a lot of anticipatory guidance. They're talking about the challenges of having a 2-year-old. Are you sleeping at night? What are your concerns? What can we do about them now? Small interventions right at the time, it's at that AAA, the triple aim. You're getting exactly what you need at the time you need it in a place that you have already developed relationships with your patients. So the other really positive aspect of it for those of us in mental health is that there is a reduced stigma attached to mental health, because people don't see that as a mental health intervention. They see it as developmental guidance. They see it as whole person care. They experience it as getting the help they need when they need it, and therefore you're able to reach many more people by partnering with the primary care providers. So this is from the National Research Council and Institute of Medicine, so you have that. The other big investment is with the family groups. This is from the National Alliance of Mentally Ill, National Parents, Caregivers, consumer group. And so they're saying that integrated primary care combines medical and behavioral health services to more fully address the spectrum of problems that patients bring to their primary medical care providers. It allows patients to feel that for almost any problem, they have come to the right place. And that's sort of what we're invested in providing. They talk about really, again, the reduced, it totally increases access to mental health services when you need them. And it also, again, from the family perspective, there's a lot of advocacy in terms of doing more and more of the integrated care. Because if you're a family and you have a child that has a significant mental health issue, what families are reporting is that all the energy that goes around going to another place and another treatment plan and another set of things to do, et cetera, then detracts from them getting the primary care that they need. So then they don't go in for that annual visit or that 6-month visit. Or that if we put them together, then then those families that are feeling and experiencing some distress about a child that's experiencing some distress is that they can get everything they need at one place, and it doesn't feel nearly as fractured as they're reporting it feels now, when they have to go here for one service and here for another service and, multiple places, and that in itself adds stress onto something they're already quite worried about. Okay, so this is why we want to do this. All right, assessing feasibility. So if this is something people are invested in, I think we really need to, it's important for the mental health provider to really understand something about the practice, your panels, your concerns, the client population, client demographics, because all that determines sort of what the services might be that we can offer. We need to understand staffing patterns, full-time, part-time, how many primary care providers, how many, just how you operate. And whether or not there are specific concerns and mental health needs, and what is if there's a primary concern, what is it? If there are like buckets of concern, what are those? And then the payer sources, who do you bill? How are you funded? That's all part of the question. And then the who's your electronic medical record provider are all need to be touched on in initial conversations. But really the ultimate goal of all of those points of discussion are what are the primary goals of the integration that you'd like to see happen. Then we want to know who are the champions for service integration, who is the point person, who do we contact, who do we need to talk to about X, Y, and Z, because your EMR provider and your billing people and your front office and the providers are all different parts of your practice that we need to know how it works and who to talk to for what. Again, thoughts from your end about how the model will be funded, and then the other side is getting to know what the behavioral health provider can do for you and the benefits we can provide, the services available, our staff allocations, and again, how can we be most helpful to you in your practice, and what are you looking for? Do you remember those initial conversations, you guys? Yes.
So one of the things that the guilty family doc thinks when they're dealing with this is, okay, I'm in the room and the kid definitely has a problem and this was a well child check and I have like 7 other patients waiting to be seen right now, and whatever serious problem is occurring is so heavy, like I could probably spend 2 hours just dealing with this family that I'm sitting with right now, and yet the access situation doesn't make it so I have those 2 hours to spend. So the guilty family doc in me really wants the behavioral expert to have a warm handoff opportunity with, so that they can dig a little deeper into those problems in real time, and in a way it's kind of a physician extender and makes it so that you're more free to go about what you're an expert at instead of kind of muddling through these really sometimes torturous experiences for both the clients or the patients and for you. So I think, it's hard to say, but you want some behaviorists to help you make your clinic go faster.
Lori, you want to add anything?
I'll just add to that, we didn't really even know fully what we were getting into until you ventured into it.
True.
And so this is all very true, but in the beginning, it was just a lot of conversations about, you know, who's going to be here, what do we need for the clinic, we really need a bilingual clinician, that would be, you know, the best thing for us, how is it going to work, where are they going to sit, like all those little nitty-gritty things, and then once you keep trying things, you kind of figure out how it will work. And so I think that really worked for us, was a lot of trial and error until we got it pretty good.
Well, thank you. It's good to know we got it pretty good. Yeah. Okay. All right. The other is addressing and being aware. Like I said, this is a roadmap. We're not delving really deep, but these are all things that you're going to have to be aware of that will need to be addressed at some point. Practice management. You know, again, people are not always, and you're saying, we kind of learn as we go. Do we want to do screenings? Do we want to do promotion activities? Do we want to do well visits? Do you want to have time scheduled for just those on the fly, you know, spontaneous consultations? Most people say yes. Do we also want scheduled visits? Most people say yes. And then you have to figure out how all of that is going to work with the pace of your practice and who's there when, and when, you know, some practices have designated time for well visits. Okay, we can't have the person go in all the time. If you've got 6 at the same time, how are you going to figure that out? All of those kinds of things, just the practice management pieces. Credentialing, what do you know? We have to have our people be okay with your people, and that's a process that we've learned about, so that's something to be thinking of at the front end. You know, as you can start that as soon as you can possibly start it and get that moving. Scheduling, again, is it half days here, is it full days there? How are we going to make this work for the people that we really want to make it work for? The other thing is, we as mental health providers have very different and more stringent regulations on sharing of information and confidentiality. So part of it is how are we going to present the provision of these services to all of the patients who come through the door? And we've decided very much, for Rocky Mountain, it's a medical home approach. And so we're in that initial consent to treat, we're written in there, and that's something that's, again, informed. So we have all of those pieces. Are we adding any behavioral health codes to the super bill, for instance? What are we doing at the front desk? Is a scheduling person going to schedule everybody, or is the behavioral health clinician going to do her own, or are they going to do, all of those conversations, again, you need to address, because those are the little things that trip you up once you get started and in there. Modifications to the electronic medical record. So we're in 4 different places and nobody has the same record. You know, that's just a little bit challenging for us to figure out how to, what needs to be modified. How are you going to see the notes that you want to see, where you want to see them, and how are we going to be able to track what we're doing, and where do our codes go? Some of them are medical codes, some of them are behavioral health codes, and how are we going to get that to work so that this is actually easy and everybody gets the information they need when they need it. Again, documentation. Sometimes we have a page that we can write notes on, but that's not available to you, and it's in no way going to meet any, let's say, our auditing requirements, et cetera, so you've got to think about that. Another big issue is to bill or not to bill. Some practices across the country decide not to bill, and they will decide that there are a number of people in your primary care practice that are not revenue generating, but they add value. And so they, like Erin was alluding to, you can argue that the saving of the primary care provider's time, the efficiency that goes with this, the patient and provider satisfaction and other cost offsets mean that we're not going to require this person to bill. We're going to capture this in our overall practice costs. Others are saying, no, this is the rate of the future. We need to know how to figure out how to bill and capture so that this is going to be our sustainability plan. And then when in the larger national conversation about bundled payments, it makes sense to capture what that behavioral health clinician is doing, so that when you go for a bundled payment, you are going to be able to pay for that in your rate setting. So there are a lot of things to be thinking about there. And then everybody getting used to codes, and I'll let you guys say something about that. Outcomes measurement. Do you want to figure out what are the gains, what are the improvements in health, and what about the family's experience? Do you want to find out about that? What about the provider's experience? Do you want to measure that? What outcomes are you interested in, and how are you going to measure them and build that into the practice as well? And all of this relates to sustainability. So I'll stop there. What do you want? Take your favorite bullet point and, and
it's my favorite. So for the billing for us, we kind of, and
can you hear her?
Can you hear me?
Yeah.
I'm sorry, but now can you hear me? Yep. Better? Okay. So we kind of, I think the billing is a very good example of kind of the, progression of discussions that we went through. And we thought initially, so we're the pediatric practice, we have a psychiatrist and an LCSW in the clinic, and we thought that they would bill through MHCD, so that we would kind of use our EMR to collect the data and give that information to them, and then they would bill. And so we kind of went on that whole process, only to find out that that was not going to work. So we had to scrap that whole plan and then start credentialing the mental health providers in our clinic. And so we're in that process now of credentialing them. I think we're just at the end and putting all the codes in our system. And so we'll hopefully be ready to bill in a week or two. But it's been a long and grueling process.
It takes a little while, yeah.
Yeah, a little while. And a lot of collaboration and discussion and kind of figuring out how we were going to do it to make it work. And then the EMR, that was another thing that we, as a medical system, did not have a behavioral health form, as we called it, in our EMR. And so we had the behavioral health providers put together what they would want, and so we had grant funding and put that together, and so now we have an operational form and we can pull data from that as we move along. So those were things that we kind of built in to be able to do it the way we wanted to do it.
I like all these. I almost would think of them all kind of coming together under the heading culture clash.
I thought of that, but that didn't sound like
there's a major culture clash that you're trying to, so the integration is actually, like, if you think about it, a false integration, because we are in ourselves and our brains and mental states are attached to our bodies. But for whatever reason, we've separated out the care of those things on purpose, supposedly to protect vulnerable populations or to make sure funding is available for mental health care. And now what we're trying to do is smash those back together, even though they're still attached, hopefully, in most of our patients. And what that results in is the integration actually having a lot of hurdles in front of it. You can't find you can't use the same money, and you can't really use the same language. We don't even call the patients the same word. You don't use the same codes, and you come up against things that, for, like, obviously I'm in a doctory situation, they'll say, like, break the glass, and nobody even knows what that means. And how do you overcome all these things? And for us, in family medicine in particular, we're kind of like, yeah, you just, it's a bit of a mess, and it's just kind of totally a mess, and stuff is not right a lot of the time, and that's kind of how it goes. And you're trying to integrate with a system that has all these regulatory layers to it that I think can be really important and we can learn from, but it's super challenging. And so I think that all that comes under the heading of culture clash, in that we forced these cultures to separate, and now we're trying to put them back together, but all of the layers that we created to separate them are still existent, and we're just smashing it back together. But I think it's kind of fun.
I'll just add one more thing. I think that we've had conversations about this too, about that it's kind of deceiving because the missions are so in line, like what we want to do and the populations that we serve we're very much in sync that way, and so that kind of leads you to believe that your culture is the same, and it's not. It's very different, and so it's a lot more challenging than it seems, but worth it again.
Can I ask a question?
Sure.
You'll probably need to repeat it for the mic. But my question is, did either of you, your practices at Brewer Clinic or Rocky Mountain Youth, did either of you try one of the other models before you went to the integrated model? Did you try a co-located, or were you involved in any mental health types of consultations before you went to this model?
Okay, let me repeat the question. So the question is, prior to attempting the integrated model, did either of these practices, Brunner or Rocky Mountain Youth Clinics, try one of the other models, consultation model, co-location, et cetera?
And we did. We had a co-located model in our Thornton clinic, and it was okay. It helped, but it was not really what we wanted. I think we were looking for integrated care and kind of ended up with a co-located model, and it didn't work very well for us.
We had a limited consultative model going on, and the problem is that the bandwidth just wasn't there. A half day of a psychiatrist who was very generous with his time and expertise. But a lot of times what he would end up seeing were the cases that were so wild that no one, he would consult one time and have that 4 hours a month, and the case was still a challenging situation even though he had done the consultation, and he was like, it would be great to know this patient more, but probably not going to happen. And so that model was really limited. So that was all the experience I had there.
Okay, thank you. Any other questions for our panel?
So, Lydia, thank you very much. And I appreciate what you said about trying to figure out and talk through all these things before you even started. But on the other hand, you guys didn't get all of this figured out before you started.
No, we didn't. But we would recommend that you at least have some initial conversations about these things before you get started. Yes?
The question is, at some point, if you didn't just kind of jump in and get that person, because you said you're going to start billing, within the next couple of weeks.
Right.
But the clinician has been there for
A year and a half.
Yes.
right.
Yes.
When you start, would you have gotten to where you are today if you hadn't just put the clinician in there at some point? Would you have continued to go through the brain damage of getting this done if you hadn't seen the real life value of this?
Well, because, like Lori mentioned, we were both aligned on the mission and what we wanted to get done. That's what allowed us to jump in. And we have had several conversations, some of them more difficult and some more easy, but it's because we could count on, I think the initial conversation is really about what are we trying to achieve here, and make sure that the alignment's there, and knowing that we have to do all of these things to get to the end point where we are delivering comprehensive care to folks who would not otherwise receive comprehensive care and get better outcomes. That's what drove it, if that's what you're asking. And that's what saw us through a lot of these hurdles and barriers. The same is true with Brunner Family Medicine. We get tripped up. It's like, okay, we got to talk. Let's do this. And we all, I'm still assuming you're on board with wanting to provide, ongoing integrated care to that client, that patient population. See, there's the culture, that patient population, because we understand the vulnerability of folks and we really want to do the best we can. So that's, it's the alignment and mission, I think, that gets you through the rest of it. But we knew we had to deal with that. We just didn't know what that was going to take at the moment. But because we've done it a couple of times, we're much better at it, and it'll be smoother with our next adventure.
Do you ever think of putting things just too much work?
No.
Oh no, did you hear that? Oh no. Yeah. I don't know if Erin would.
Well, what I'll just add to that is that I remember from the beginning the conversations that we were having. It was meeting after meeting after meeting, and feeling like we had to answer every question and address every issue before we started. And then we finally got to a point where we said, let's just go. Let's just go and start and get the clinician in there, and then we'll figure everything out as we go. So it is a little unsettling, and you feel a little risky, but it was great, I think, that we just did it and it worked.
Right, and the funny thing was soon after we had that conversation, I went to a national conference on integrated care, and we were talking about these struggles, and finally they said, oh, just do it. It's like, oh, well, then we're on the right track, because we just did it.
Extremely messy and never perfected in the first place, so you might as well start in a pretty bad spot and go from there, since you can at least...
It'll only get better.
Yeah,
right, it'll only get better.
So I like the idea of just kind of mashing it and finding out. But it really helps when the organizations have gone through this a little bit, because then they can grease the wheels as far as some of the very obvious regulatory or licensing or credentialing issues go. And if those can be smooth, then I think once you kind of take care of all that, then you can just smash it together and then start to repair it.
Everybody wants to do this now, right? Yes. Okay.
What did you experience as far as resistance to implementing this model?
Sure. So the question was, what did we experience as far as resistance? And I think that's a really important question, and you got to know a little bit about my clinic. It's a family medicine residency clinic, and so there's a lot of teaching about the biopsychosocial model, and there are staff members who are dedicated to educating about this kind of thing, and there's a lot of buy-in from the clinicians, and so it's kind of, we hope to have it be a more progressive environment, so it's not like there are clinicians who've read their last book 20 years ago or anything like that. And I think some of the challenges come more with the clinical pace culture clash, just that we're going to be seeing patients every 20 minutes, and that's how that's going to be, and how do you figure out how to get together in that space. But there weren't any particular resistances from the providers. I think we all really want, we're all ever more seeking out, it almost makes it so you're looking for problems, which is not the greatest thing to be doing, but sometimes, especially when it's in young people, if you can identify those problems early, then it's okay to kind of be looking for that problem. So we're all a bit more looking for the behavioral problems we might identify.
So for us, I think the biggest resistance was kind of figuring out or being in line with what the behavioral health providers were going to do in the clinic. And so we kind of established early on that I'll talk about this now, that we kind of break up the provider time into 3 sections, and so a third of the time would be in the provider room talking to providers about medical providers about patient issues. Just discussions, no patients there. A third of the time would be the consultation, where they would, the warm handoff. It was a well check, and then the behavioral health person would be pulled in. And then the third of the time would be one-on-one with the patient, the behavioral health provider only, no medical provider. And so we set that up to make sure that we wouldn't go into a co-located model and just have the behavioral health clinicians be seeing patients all day. And sure enough, it happened where that's what was happening. We had such a backlog of patients who needed help. We have a very high needs population, and so it was kind of like, these are mental health problems, we're going to give these referrals to you. And so we had to do a lot of, kind of restructuring it to say that's not what we want. We don't want these people scheduled all day, seeing patients one-on-one. And so I think that was some of the resistance, was saying that that's not what integrated care is, and having to keep redefine it and go over it until finally I think everybody got it. And I think we're at a very good place right now where there's a deep understanding that consultation and addressing things in the moment is supremely helpful, and more helpful oftentimes than the one-on-one sessions with patients.
Okay. Any other questions? Okay.
Did the two of you know each other ahead of time? And do you use the same treatment model? You mentioned evidence-based care. We've run into different philosophies among our psychologists.
Okay, we'll go after that chuckle in a second. We have not, oh, I'm sorry. The question is whether or not Lori and I knew each other prior to deciding to jump in, and what were the sort of the models of care for behavioral health, because there's sometimes differences even within the mental health providers. And you mentioned evidence-based practices, for instance, and how you manage. We did not know each other. We got to know each other pretty well, pretty quickly. And I think when I talk about the practice management, it needs to be, I think, understood, and the behavioral health consultant comes from a very different, talk about a different culture, a very different model of care than what providers do in pediatric primary care. Like you mentioned, the 20-minute visits, the documentation, the hallway consultations, and to come from being trained traditionally in mental health, where your session is with an evidence-based practice and it's an hour, to change from even for the mental health provider, to switch from a traditional mental health model to a fast-paced, make a difference, focus on the problem, get something done, all of, engagement, intervention in 20 minutes is a huge, huge shift for mental health providers. And so I have a slide about what you're looking for in terms of a mental health provider, and it's somebody who has much more of a population-based approach to care, meaning they can do promotion, they can do prevention, they can do anticipatory guidance, they can do very short-term and feel comfortable and great about the work that they're doing. There are people that don't ever want to make that switch. That mental health service provision, therapy is where it's at, and that requires your 45-minute hour, those kinds of things. So you really do have to choose well the person you put in a primary care practice. And you need to be comfortable with consultations. They need to be able to focus on the presenting problem, and they need to be able to give you useful information in that hallway conversation. They need to have a broad range of experience with little ones all the way through emerging adults, if that's who you serve in your clinic. They need to be able to see those short interventions as extremely helpful. And we have evidence that they are, but that's not everybody who's trained, again, in traditional mental health can approach things that way. So you really have to be careful about that person you select to be a part of your primary care practice. It requires a certain level of flexibility and a certain level of training that most people don't get when they've been traditionally trained as LCSWs or PhD level psychologists, that's who we have in our primary care clinics. I don't know if that addresses your question.
We've just had conflicts for that very reason.
Mm-hmm. Yep. We both agreed about who we wanted in the clinic, and then we found amazing Rachel Lund, and so it's working out. Right. Do you want to speak to that, the pace and the models of care?
No, I was just laughing because my wife's a psychologist, and we talk about the theoretical approaches to the patient and how that's still a subject of discussion.
Mm-hmm. Yes.
We're still going with the germ theory, like
nature and nurture. Okay. Yeah, I would be asking people about their experience with brief solution-focused therapy, brief strategic interventions, those things that we know make a difference in a short period of time, because they're a better match for the pace and concerns in primary care. Okay. Anything else? I'm going to talk fast. Okay. Some of the details you need to address. I won't go. Role clarification is very important as we go into this about what is the role of that behavioral health clinician and what will they be doing. Speaking to your point, what are the types of interventions, the pace of those interventions? Do you want to do, like Lori was describing, a third consultation, a third one-on-one? How do you want to do that, and who's going to do that, and who's going to do the warm handoff, et cetera? What else? Contracting, we do have to do that. I haven't mentioned it yet, but just keep that in mind. The onboarding, again, for the behavioral health consultant, be pretty thoughtful about how you want that person to get to know you and how you're going to introduce them to your clinic and your providers, and are they going to be doing training and when, and what kinds of supports for staff, or do you not want supports for staff and it's all going to go to the individual patients? Those are the kinds of things that would impact your onboarding procedures. Who do they need to know, and who are they going to be working with first? It helps to just take bites of the practice at a time instead of, well, we did throw people in there, but I would take that back now and do a little more thoughtful onboarding planning. Reporting and supervisory relationships, how are those going to work? You need to be thinking of that because in this model there are employees, so we have to provide ongoing supervision and have access to the employee, but they also need to be part of the practice, and there needs to be a point person there and the connecting point there and who they go to, et cetera. Lori spoke to ongoing communication and check-in meetings. That is a requirement. I think I'll build that into my next MOUs and contracts, and it really is the meat of how you get this done. And then, again, the care and the outcomes that you want to look at, how you're going to obtain that data. Billing, if you decide to do the billing, that is a process in and of itself. And takes a particular expertise, and then we need to find out from your end who to talk to and how to get all of that worked out as well. Are there questions about this level of detail? Okay, I'll move on. Touch points. You just want to make sure that these are on your list of things to be considering. Feedback loops. Again, really important. How is this going for patients, providers, for the front desk staff, the consultant? What's working? What can be improved? Is the infrastructure? We have found out, 3-6 months, we should have asked that, or we should have built this. We know a lot more, so our template that we would be able to share with people is much more filled out than it would have been a year ago. And are we able to do what we set out to do? Again, we're probably still aligned on the mission and vision, but have we gotten there? And what else do we need to do to get to that point? That's what we're speaking to here. We have to have an ongoing feedback where we haven't done this enough to know this roadmap is the best practice. It's a little different in each place because the primary care practices are different, and the needs are different, and the populations differ. So we have to keep making sure that we're doing what we set out to do. I think that's really important. Any comments on ongoing discussions or?
I'll just say for us, we have we call it a design team meeting, so it's a once a month. We all get together and talk about all of the issues that were on the previous slide. So coding and billing and consents and all of that, policies, procedures, the EMR, pulling data, those kinds of things. And then we recently set up, and it's working very beautifully, a monthly meeting with the providers. So they have a once a month meeting to talk about any kind of issues that are coming up for them, if it's patients or any other issues in terms of scheduling or different things. That's right there in the clinic, and they're doing that every month, and they're both very, very different but very important.
Okay. All right, moving right along. Okay, so I mentioned the behavioral health consultant and the core competencies. When you're looking for a match to work in primary care, this is what you'll find in the literature in terms of what you're looking for. So this needs, if you're looking for a behavioral health consultant, this needs to be in the job description. And the clinical practice is what I was talking about before. Are they versed in evidence-based practices that are very short-term, motivational interviewing, solution-focused interventions, anticipatory guidance, psychoeducation, and across the age range? That's that clinical practice piece. The practice management is, can we do that in 20 minutes? Can we figure out how to have ongoing spontaneous consultation time, and how do we fit in all the different pieces that you want into somebody's schedule? The consultation skills I mentioned earlier. How do I work with a primary care provider and answer the question that's being asked in a 2.5-minute conversation? How do I make myself useful and the feedback I'm providing useful? How do I cut to the chase? How do I get to the core presenting problem? And how do I do a functional assessment? We're used to doing, some of us are trained in the traditional model of doing 2.5 hours of assessment and writing a beautiful 6-page report that nobody reads. So this is quite a change to go to a functional assessment where you've got a few minutes, you focus on the issue, you figure out what can be done, what the follow-up is going to be, who's going to do that, and go. And you're on to the next, hopefully you've been helpful to the doc, and you're on to the next, they get to go on to the next thing, and you get to go see your next person as well. Documentation skills, again, very different from what folks have been trained in. How long is our treatment plan, would you say, like in our... So,
3 or 4 pages.
Yes.
Yeah, we do this 3 or 4 page treatment plan to justify an intervention, and we need to make sure that everybody can go to a SOAP note that's useful to the primary care provider, that in a number of sentences, you know what you need to know, you know what the next step is, you know what needs to be attended to. That's, again, a very different shift, so that's something you really need to inquire about and make sure someone can demonstrate the capacity to do, because some people just don't want to do it that way, and some people are excited to do it that way and see a difference. The others are just, the team performance skills and make sure that everybody, how they work collaboratively, because this is certainly a collaborative venture, and then the policies and procedures and those basic administrative type skills. But again, it's important that you're looking for the right person and that's a good match for primary care. The pace, the culture, as you've mentioned, is very different. So you need folks that can learn a different culture, feel comfortable in that, and perform in a way that's helpful to you within that culture.